Yeah. We good? Okay, thanks for joining us, everyone. Yeah, today's webinar is the Analysing Economics of COVID-19, Methodological Challenges and Data Gaps. And so my name is Chris Painter, and if you're not familiar with us already, this is run by HITAP, so part of the Ministry of Public Health in Thailand. And this is part of our series of technical health economics webinars. So if you've missed the first two that we've had already, you can find more information about these on our website, and all the kind of information and slides available up there. So today, we are lucky enough to have Anna Vassall and Mark Jitt joining us from the London School of Hygiene and Tropical Medicine. So Anna is Professor of Health Economics and Mark is Professor of Vaccine Epidemiology. And they've both got kind of a wealth of experience in economic research, particularly in infectious diseases in the UK, as well as around the world, with particular kind of expertise as well for low and middle income countries. Both have been doing a lot of work on COVID-19, so we're very lucky to have them here today. So if we got the agenda up. Perfect. So as we're running kind of tight to time, just a couple of kind of introduction and housekeeping things, but then we'll have 30 minutes of presentation from Anna, and then 15 minutes Q&A, and then 30 minutes from Mark, and then 15 minutes Q&A, and then we're aiming to finish in about an hour and a half. So we'll try and keep to that. Cool. And then housekeeping. Next slide. Cool. So if everyone could keep their microphones muted, we're going to try and kind of field questions in two ways. So if there are presentation kind of clarifications, just feel free to write these in the Zoom chat throughout. And Mark or Anna will try and field these directly in the chat box maybe, or if they're kind of particularly important, maybe we'll come to them in the Q&A section as well. And then any kind of longer questions, feel free to write these throughout, and we can discuss these and pick them out during the Q&A session. Also just a note that we will be recording this session and hopefully be sharing the slides with you in the coming days as well. Awesome. So with that, I think Anna is up first, so I'll pass you over to Anna. Anna, are you okay to share your screen now? Okay.
Hi, so first, Chris, I just want to check that that looks okay.
Yeah, all looks good on my screen.
Hi. Very glad to meet you all. Unfortunately, I can't see you all, but very pleased that you could all attend today. So I'm going to talk a little bit, well, we're going to sort of split this presentation in half with Mark and I presenting different bits of it, but I'm going to focus on some of the economic aspects of COVID and try and reflect over a year's work on the sort of methodological challenges and remaining data gaps. Just to say, you'll see as we go through this presentation, we're presenting work funded by a wide range of donors and also from a big team. So it's really not just me and Mark. Much of this is work done over the last year by a whole range of other people. Just checking, I thought that would go forward. It did run having a bit of, let's try that. Sorry, I'm just trying to figure out how to, okay, great. So I wanted to begin with a bit of a whistle-stop tour of the types of questions that we've been asked by policymakers over the last year. I think there's been a great sort of deal of discussion of what is the role of health economics, with some people arguing that health economics doesn't really have almost a place in the pandemic. It's something that comes afterwards, that almost cost is no object. And I think we've all heard that in the news and various sort of discussions in the public domain. But I want to give you some idea of how health economics has been used, even if in a slightly unconventional way, more the sort of elements of health economics and particularly economic evaluation. So I think when the pandemic just started, particularly in the UK and some other countries too, I think policymakers ask themselves the question, are really trying to grapple with, is this actually an emergency? And they start to ask these different questions. So They start to try and understand whatever's happening, will the health system cope? That was one of the first questions we had. Is it really an emergency? Is it going to breach our health system? Will this have a substantial macroeconomic impact? And really the most fundamental question in our country, how many people would die? Do we really need to change tack? And you can see that in sort of the early modeling results. They were very broad, but still modelers and economists were trying to answer these questions. They were being asked and people tried to answer them, even though there was very little information. When you sort of go beyond those first couple of months, you get to a sort of second stage, which is like we've accepted as a policy community, we are in a sort of state of emergency, but we actually don't know yet what to do about it. So let's try and hold it back. Let's try and mitigate it till we figure out what we're going to do about it. And you get questions about how much intervention do we actually need to sort of hold this back? Should we now invest in capacity? So some very early questions we had from the World Bank, but also domestic governments saying, actually, should we now take out a massive loan or get a massive grant to start building hospital capacity? And even though no tests or treatment or vaccines are there, actually you have very similar type of analyses as you do when you look at target product profiles, is trying to understand actually what technologies are going to impact this emergency. So even if you don't have any of those characteristics, policymakers are still trying to decide how much advanced commitments they should make, how much they should invest in production capacity for vaccines, et cetera, et cetera. So you start to actually have health technology assessment, maybe not done on the grounds of cost effectiveness, but looking at the costs and possible impacts of these different interventions, if you like, sort of separately. And you have this question like, how much money do we need now and are likely to need, and who do we go for that money? I think once that sort of once that first wave in many countries had been through, but you understand you are now in a sort of prolonged emergency state, and also it's a part of acceptance and beginning to see the technologies and response being defined, you start to get more specific questions. So now, how is the epidemic behaving? Why is one country doing differently than one another? And why can we not explain everything we're seeing now? We got a lot of questions, I think, in July about why is the epidemic playing out differently than what was expected when you had no information in the first 6 months. Now you have some more information. Also, you start to get much more nuanced questions that we're trying to answer with, as I say, not necessarily economic evaluation, but looking at costs separately and perhaps income impact separately, is how when we get these technologies, how will we begin to implement and target them? And finally, what we're seeing now, and I think many countries are grappling this, is actually what does the post-emergency look like? You know, when do we start to remove our NPIs? What does the long-term position look like if we have vaccines available, making assumptions about different levels of immunity? And how much do we have to fundamentally change our health budgets and our health resource allocation, and also more broadly economically, to deal with the fact that the effects, at least the pandemic is here to stay, not necessarily in an emergency setting, but it's still a pandemic. It's still in an epidemic stage and eventually may move to endemicity or be eliminated. And then this basic sort of human question is, when will this all end? Which we know happens in many other infectious diseases, but actually we'll begin to get that kind of question now in many countries. What's the end game here? So I just wanted to, you know, I think the reason I'm saying this, all these questions are questions that we're used to asking about infectious diseases, but we've had to try and answer them all within a year. And I think the interesting thing for me has been that we need to estimate costs. We've been asked to estimate impact, but it's actually been the lack of bringing together of those two things that has been different than when you're dealing with normal epidemics. So the actual decision and weighing of those two elements is done in a different way than we do in conventional cost effectiveness analysis. And also, of course, as you're all, I'm sure, aware, you know, you can see these questions are taking a societal perspective rather than necessarily a pure health system perspective. So if we had foresawn this, and if we had all our methodology and data available, this is what our perfect model would look like. And I wanted to start with this to answer these questions. You know, if we were really ready, and apart from having a perfect model, we would also have 100 economist modelers, at least 10 in every country around the world doing this. But that was not the case. But just as a starting point, this is the perfect model. We'd have the outputs, the different sets of outputs. that policymakers need in terms of measurement and empirical measures. So we'd be able not just to look at health sector costs for the specific disease, but obviously the impact across the sector. And the same way we say GDP impact by different sectors, but also at an aggregate level. And likewise with health impact from COVID, but also, as many of you have seen, excess death type measures already to be produced, sort of system-wide measures. We'd have it though, that model producing all the metrics we're used to, whether it's net benefit ratios, return on investment, ISAs, distributional indices of various times. And we'd have it be able to deal with different sorts of interventions, both health and social interventions, because a lot of people are talking about we have to measure health and social effects, but I think one of the challenges has been trying to actually characterize both sorts of interventions working in tandem with one another. And that's still something which is work in progress, if you like, still a gap. And finally, these models would actually be interrelated, or the underlying infrastructure of the modeling approach would be interrelated, because there are feedbacks between different elements of the health sector, economic behavior, and back and forth again. And we'll come back to that as we go through this talk. And finally, of course, we'd have real-time, representative, and somewhat universally, if it's a pandemic, globally, data to feed into these models. So that's ideally, if we wanted to inform all those questions rapidly, that's the situation we'd be in. In practice, and I'm sure many of you sitting in health economics units or interested in the area probably have experience or part of that infrastructure. And it was very much the same within the London School, that we had people who are working in infectious diseases, some in respiratory diseases, some in vaccination, other economists who were looking at flu in the UK, many different areas of work. And we had data from different areas. For example, we had cost data from TB, which is respiratory disease, cost data from vaccination, but we had bits and pieces. And what we've tried to do, I think, in the last year is not necessarily having the perfect linking model, but at least getting the people who have been working in each of those different areas come together and as far as possible link, and as far as possible be consistent in the scenarios. But it's difficult, and you can see the huge amount of people you need to be involved. You need an epi model, you need a macroeconomic model, you need a microeconomic model, you need people actually doing underlying cost models. And across all this, as we've seen with this pandemic, the effects are not equal. And so somehow it's not just you're doing this for the whole population, you're actually trying to specify all these models. Ideally, you'd be trying to understand within all these models how it's affecting different population groups within models. So you need to deal with heterogeneity and equity. But again, that's incredibly difficult to get working across all these things. So this is the way that we've dealt with it, partly because of our sort of historical capacity. But yeah, and I'm sure, as I say, everyone else, and I suppose the other message I want to give to this is, even if you're not sitting in a unit as large as, say, the London School, and even if your contribution or what you're able to do is part of this, that's really important. It's that you shouldn't be held back by thinking, well, I don't have a macroeconomic model, but you should try and find partners who can sort of support you in coming to the whole picture, or at least link together and reflect that in your interpretation of your results. Just again, I mean, I won't go too much into this particular issue, but we did start off trying to understand where the interrelationships were. And I think that was the starting point right in that emergency phase, when we were thinking, how do we bring, what different bits do we need to put in that? So we did, and just this refers you to a paper with several of our partners, try and sort of sketch out all the interrelationship. So here you see a map which takes us from the macroeconomy into household behavior, linking to different risk factors, which then inform health outcomes, which then change the epidemic, which in turn feeds back into the macroeconomic response. That gives you some idea of the feedbacks between the economic and health systems. The other thing I should say is I'm going to pick out today work from the London School, just because I know it and can present it in a better way and answer questions in a better way. But I want to say, right from early on in this effort, I think we haven't, I think it's been very difficult, not just for ourselves, but other people, to immediately get collaborative funding. but lots of different groups around the world have had to respond to their own ministries. And I think what's important, even if you can't set up those big research projects that sort of set up collaborative funding, is to work together as a network. I hope this webinar contributes to that, but I'd also like to say that we've set up networks on c19economics.com and .org as a way to try and bring researchers together. So I do hope that people look at that site if you haven't seen it before. And finally, I'm going to present work from London School. I haven't referenced it all, some of it's in preprints, but if you need to access the work that's presented today, it is all available from from our websites, either from the CHILL website at the London School or CMMID. So just to say, I haven't put all the references here, but please look at those if you're interested in any of the studies we present. So I think just going back to that sort of very early stage, what was the first work that we did? And this is not claiming that this work is at all valid now, but it's just to sort of give you an illustration of the way that we work through this. I think we saw initially a lot of commentary in high-income countries about bed capacity. And I think in many of the settings that we were used to working with, we realized, well, maybe, yes, ICU bed capacity will be a constraint, but there are many other constraints. And I think this is the way that low and middle income countries have fed back into what's happening in high income countries too, because they've really highlighted, and we try to highlight through this work, that it's not just ICU capacity, it's general bed capacity, and also it's human resource capacity that constrains health systems. So we did this very early work looking at different sort of trajectories of an unmitigated epidemic with different assumptions. And at that time, we had no idea about severity, and just tried to illustrate in different settings how quickly with an unmitigated and no access, we would not only just breach ICU capacity, but also general bed capacity and the capacity of the health workforce. The other thing out of this work is we estimated health systems costs, which I'll come on to in the next slide, which were substantial. So we wanted to be clear that this was not just a case of your ICU wards becoming overwhelmed, but this pandemic posed a threat to the whole of the health system in its entirety. And as we see, that has not just been a phenomenon in low and middle income countries, actually is equally and perhaps even more so a phenomenon in high income countries, where they built lots of beds, but then realized they didn't have the staff. So now when we define beds, we're actually defining a fully staffed bed with capacity rather than just a physical bed sitting there on an empty ward with no staff. And then one of the second questions that I had in that trajectory was, we were also asked very quickly, well, what are the financing needs? Particularly from our perspective, we weren't doing so much in-country work, but we were trying to inform those global funders of how much money needs to be raised, organizations such as the World Bank, etc., to support development financing in this area. And again, we produced, and this was a preprint, and now we're doing revised estimate of the overall health spending by different countries by the proportion of total health spending, and found some quite substantial results, that it was going to be 10 to 200% if it was an unmitigated epidemic of current health sector spend. It varied considerably by country, which we've also seen play out. And our figures were also, the World Health Organization has also done similar figures using a slightly different method, and so did the IMF, and all of us were coming out with this consistent message that if you decide to respond and treat and care for everyone with COVID at this point, it will, in many countries, it's going to breach the total amount of health sector funding. More recently, on the cost side, we've been sort of the question which has come up later has been, now we have technologies available, particularly vaccines, which I'm sure we're all in the middle of trying to understand and analyze, is what will be the costs of delivery systems for vaccines. So again, ourselves, but not just ourselves, of course, also global agencies such as UNICEF have been trying to do some rapid estimations of the costs of scaling up vaccines globally. And we're in that kind of early stage where we're making some very, very simplistic assumptions. So obviously we have some indications of pricing, but not complete indications of prices. It depends which vaccines become available over the next year. And we've had to make assumptions about human resource, whether it's facility-based, campaign-based. We've had to plan out, how people will reach door to door, different target populations, and also the health system markup. And then sort of estimate the overall costs of delivery. I think these costs are highly, highly uncertain still. I saw some results from Kenya, which actually also said if some of the plans there were to happen, this would be major proportions of the health budget. I think much depends, again, on the constraints within the health sector and how easily it is to expand on those constraints, particularly the human resources to deliver campaigns. So I think there's still, this is very early stage, and I think in the next few months we're going to get a much more thorough investigation of the real costs and the real capacity constraints of rolling out vaccines at the delivery level. One thing I should say, and again, this is work which is very much preliminary, is when you look at the cost of the vaccine delivery plus the cost savings potentially, just even to the health sector. We, and Mark is going to speak more on this, are beginning to look at overall net costs and seeing that in some instances, there's still, expanding vaccination will be cost saving to the health sector in the longer run, given the amount of reduction in terms of care and treatment being provided. So it may be an issue of short-term constraints versus longer-term benefit, and how we relieve those short-term constraints without damaging the rest of the health sector. Quickly moving on to another area of work, I come from a background of TB research, and TB research has always been important, and to look at the consequences, not of NPIs or social distancing, but just of the cost of illness on patients itself. So again, very early on, we wanted to highlight that it's not just about health sector capacity, but it's also about productivity loss if people are sick and ill with COVID. And actually, I was asked a question yesterday from the UK, now looking at long COVID, that this still remains an issue, that COVID itself has an economic cost. So we did some early work, and this was done by Sedona Sweeney, who's done a lot of work in TB as well. And we found early on that the actual cost to individuals just of getting the illness is probably equivalent to the cost of treating in hospitals. We just wanted to, it's not that we think this data is that accurate. We took it by making some heroic assumptions about the kind of cost of illness of TB, but as an area of research and a gap to understand now, particularly around long COVID, what are the long-term effects of the cost of illness, I think is still a major gap in our understanding. And then finally, I'll stop soon, but going on to sort of estimating the macroeconomic side. And this is actually some work from Imperial, and it's from the UK. And I just thought this was just a very nice illustration of perhaps what we need to be doing. And this sort of shows us different epidemic trajectories under different types of interventions. In this case, they were looking at schooling interventions and various levels of lockdown. And actually it sort of shows you on this graph the level of GDP. So you can really directly see the GDP, in this case, hospital occupancy trade-offs for the UK, but you can imagine this kind of analysis being done with different kind of metrics on the y-axis, for example, deaths. And I think Mark is going to come back to that. From our side, we did work with the Ministry of Health in Pakistan, trying to look at the macroeconomic impact of COVID there, of different scenarios, of different lockdown scenarios. I think, I don't want to speak for the macroeconomists, I'm not a macroeconomist, but for my colleagues and the others working in this field, I think this group had done previous projections of the macroeconomic impact of a flu pandemic. This pandemic has totally exceeded any estimates that they previously had. I mean, I think we've all been experiencing that. So I think there will be some reflection after this pandemic of how were we so unprepared for the extent of the economic impact. So I think that's generally a key message. In Pakistan, you can see the huge impact there of lockdown. And I think what you see, and just to explain this table a bit, you see a sort of mixture here of the macroeconomic interventions themselves, the labour supply losses, which are really the cost of illness, and the actual hospital costs and the balance between the two. The hospital costs, interestingly, if you look across the whole sector, are actually positive, because in a sense they represent increased productivity in that setting. So that's a bit of a different perspective than our normal health economic or micro perspective. But clearly, as we all know, the sort of heavy interventions is on the MPIs. What was interesting, and I think this is really perhaps the misunderstanding, is that it's not a direct trade-off between the macroeconomic impact and the health impact. In many cases, it's about timing. So for the example of Pakistan, is you still hit the impact later on because the epidemic still comes up later on. And we've seen that in the UK, that actually the trade-off may be less, that if you have MPIs done earlier, you may not have to, you may actually prevent health impact, and also you may prevent lockdown if you're sort of more macroeconomic impact, if you accept that you're going to have to put in major NPIs at the point at which your hospital capacity is breached, if that's your main constraint. Of course, if that isn't your main constraint, if you're happy to let your hospital capacity being breached, then the trade-off would still exist, because you may continue never to lock down and just take the health impact. So I think that's I'm just going to check, I might have one more slide, because I think Mark is going to summarize across the 2 slides. No, I have a couple more slides. I hope you don't mind if I'm 1 minute over. I just want to highlight the last thing. Thank you, Chris. I see your thumbs up. Just about equity. And I think one of our frustrations is we would have loved to have done those models and actually had them disaggregated by different social economic status groups. It's clear that the decisions of individuals are based on a balance of their health and economic risk, that those who face huge economic risk are unlikely to be able to protect themselves against health risk. And there's a relationship between the two. And what we've seen in other diseases is diseases don't spread evenly across populations with different social economic status. If you look at TB, it is predominantly in lower social economic status groups. And that's because it becomes endemic, because the poorer groups cannot protect themselves from the risk factors that richer groups are able to do, or more well-off groups. So to me, it's been, it's always a concern, not just from what we see now, but also in understanding the future of an epidemic, is to understand how it is affecting different groups in society, not just by age, but also by our ability to protect ourselves against health risks. Because I think fundamentally that will determine the pattern of the epidemic in the long term. I mean, Mark may disagree, but that's my view. So again, faced in the early stages, we literally did some work with no data on inequities coming out of countries, but just trying to highlight this difference between health and economic risks, which again, my colleague Sedona Sweeney started to look from sort of routinely available data in the public domain on sort of the labor force participation, and tried to understand in different countries how different quintiles would be able to protect themselves both economically and against health risks. And I think our really ambitious intention to start with was to think, can we bring this into the modeling? And there's various reasons why we haven't been able to do that, but at least we've been able to do it alongside the modeling. And then I think probably some of you are familiar with the left-hand side type concentration indices, a typical way that economists represent inequality, to try and sort of present that inequality, and then try to show for different countries what percentage are able to protect themselves against these different risks. I think one of the challenges is why, and this is very early work, and now we have real data rather than just taking it off and imagining from these secondary data sources. I think unfortunately one of the challenges is, even though we can get this kind of data, and maybe we'll get more and more of it, is bringing that into modeling, because models need an additional part of data, which is how contacts mix together. And while there may be some information in the way that different age groups may mix with one another, it's very hard to measure, as you can imagine, if you ask people, well, did you mix with someone who was poor today or someone who was rich today? How do you understand how, if you look at all that individual risk, it comes together in the way that people contact with one another to drive the epidemic? And that to me is the missing piece of information, because it's not because no one has thought that that's missing, but it's actually something incredibly difficult empirically and in measurement terms to get at, and is perhaps one of our remaining data gaps or challenges that I think will be key going forward, but is still probably, at least today, is still a struggle. So I'm going to stop my screen sharing now, because then it will be over to Mark. And I think, Chris, there's now some time for question and answers, and thank you all for listening.
Yeah, no, thank you so much for that, Anna. And you've run perfectly to time. That's bang on half an hour. So thank you very much. Yeah, we've got some questions coming in. So I think a lot of them actually about non-pharmaceutical interventions. And I think generally like a few comments on how, well, I think there's one particular question about whether it is advisable to do lockdowns. I think that you might feel uncomfortable answering that for Malaysia just off the bat. But yeah, I think there was one on, have you published any studies on the economic impacts of conducting lockdowns? I'm not sure.
Yeah, I think on the study, so the one on Pakistan, we've just got the final draft of the paper. Again, people are welcome to contact me if they're specifically interested. So they're welcome to contact me and I can check with the authors, but it will be a week or two away for the one on Pakistan. The one that I presented on for Imperial is actually on the Imperial website. And please look at c19economics.org, because we are doing regular searches of not just the health economic, because I can imagine many health economists don't have access to the economic search engines. So that's what we're trying to do, is search EconLint, MBBI, you know, the more macroeconomic sites, and make them accessible to health economists. So I would say watch that space. Definitely our Pakistan work will come out in a few weeks. But it's not, as I say, it's not just us, and please go on that site and we'll try and post macroeconomic impact studies. I mean, I think they look at the impact, but they're not, on the question of, you're right, I'm not going to recommend for Pacific countries, but I think we talked about health system constraints, that there are things that governments feel able to do or not. I think one thing that's emerging, and definitely from a previous webinar that you can watch recorded, I don't want to keep advertising the site on that site, is that for countries like South Africa, there are real macroeconomic constraints on what they're able to do at this moment, having suffered, if you like, the macroeconomic impact of the first lockdown. So richer countries like the UK have many more options. And I think that's something that is evolving in time. So it's not do or don't, but I think it's important for people to understand that for some countries, they just are not able to do some of those interventions at this point because of they're basically not able to keep their fiscal balances, and they're just not able to. So again, just please look at that site for emerging work, but also commentary and experiences from countries.
Mm-hmm. Yeah, I think that's, you're right to point again to COVID-19 economics, because that definitely is a really good resource that everyone should make use of. I think there's another question on what kind of issues or data gaps have the research community encountered in terms of estimating costs to household and businesses. I think, that's certainly a difficult one to
Yeah, no, that is, I think, I mean, I as I say, I haven't looked specifically at the cost of NPI's specific sectors. I mean, I think that is something, I mean, again, I'm just referring to what I was listening from someone who was presenting from the South African Treasury, that governments are monitoring, but they get the data late, often post hoc, but clearly, there are, governments and finance and treasuries are monitoring impacts on specific sectors. From our side, in terms of the cost of illness, one thing we're trying to look at is we run nationally representative TB patient costing studies. And we're trying to at least look at how cost to different patients in terms of the cost of illness has changed, because we have patients in there who've had COVID. But again, though, the weakness of those studies is they're picking up people who've accessed care. They're not actually representative of people who never get access to care. We've always had that trouble with looking at cost of illness, is how do we capture those people? So I assume that there are people trying to figure out how to set up appropriate survey instruments around this. But at the moment, it's still something we're trying to, at least from our side, we're trying to figure out. The only other thing I would say in Pakistan, we're running through Ipsos phone surveys on social contact behaviors and trying to get not sort of questions on income changes for households, but we don't have a sample size big enough to pick up necessarily the relationship with particular interventions. So we'll get a general picture, but not be able to link that to, you know, this household had a higher one. We just don't have the sample size to look at those kind of comparisons. Yeah, I'm curious. I don't know with the demographic health sites or the surveillance sites, whether there is more opportunity to do that kind of work too.
Thanks. And then just another question here on, sorry, it's just jumping around on my screen. How's it going? Yeah, how would someone go about measuring different contact rates between socioeconomic status groups? I mean,
okay, I'm going to hand that one to Mark. I know we're trying in Pakistan to ask some questions, but you've really got the expert on contact measurement here. So Mark, sorry to leave you with that.
Well, usually these are measured using contact surveys. That's the sort of best way to do it, which is to ask people to fill in diaries, ideally prospectively. So as they go through the day, they fill in these diaries. If people are willing to answer further questions about their socioeconomic status, like income or wealth indicators, you can then link that to socioeconomic status. I mean, there are other ways to collect these data. There's also mobility data that, for instance, mobile phone companies or internet companies like Google collect. These are usually not, I mean, these are not available on the individual level because would violate lots of data protection regulations. But there's sort of some geographical aggregation you can get just on the data available on the internet, and some sort of more fine geographical aggregation you might be able to get through arrangements from them and permissions from ethics committees and so forth. So that's another way, but really the contact diaries are the best way.
And on that, Mark, I know you didn't mention, but if a country hasn't conducted a contact tracing study already, you, I believe, have authored a paper where you can project them, no, based on some other data, but I don't know if that works with socioeconomic status as well. Is that right?
Yeah, that is, we do have, well, two papers, one a recent update, which is a preprint, which we authored together with the National University of Singapore, looking at producing contact matrices for all the countries in the world using routinely collected data. So not empirically collected, but trying to project them using household size and so forth. But they, yeah, you're right, they aren't stratified by socioeconomic status.
Ah, okay. Okay, cool.
And Mark, I was just wondering, I answered some of those other questions. I don't know if anything you want to add to any of the other questions that I answered.
That's great. I think you've given great answers. And there are a couple more questions that appeared in the last few minutes.
Okay, okay, let's try and do
them. Just kind of, if you pick out some, feel free. I'm just scrolling through them. There's loads in there now.
Okay. I can't actually see them. Sorry, it's part of the thing of setting my screens all being the same to do the presentation in the way. So it's really helpful. You can.
I mean, for the question on attempts to estimate financial catastrophic costs for households, individuals, or businesses, do you want to talk about? I think Sidona's.
Yeah. So I think that as I say, because of TB, that's what we try and, you know, that's what we're trying to do. So I don't know. I was asked this question. I don't actually know of surveys doing that. I would imagine the WHO and the people who run the, you know, support the demographic health service and the WHO measures of catastrophic cost. I don't know whether those surveys have stopped during COVID or whether they're continuing them. I think from our side, we are looking at the TB, as I say, the TB catastrophic cost surveys that have been running, and I think some have still been running through COVID, particularly the ones that we're using phone surveys, and seeing if we can use those to find data on catastrophic costs. I think it's like with the health service costs, a lot stopped in the first wave, but I think some of the research in this area has begun to sort of those surveys have continued during the second wave. So I think we're much more likely in the next couple of months to see people who've looked at this. But at the moment, I'm not aware of new data in the public domain yet. But we are, as I say, we are looking at our current surveys to see if we can analyze them in this way.
I think one question I just had is, because it's become more topical, I think, in the past week or so in the UK, at least, about introducing potential travel bans or mandatory like quarantining in hotels. And that's something that I've not seen a lot of in the kind of economic literature in terms of the impact. It's more been blanket travel bans or not blanket, but or no travel banning at all. And then obviously that's something that has been in place in, for example, Thailand here. That's kind of been part of the entry rules to Thailand for a while. And I was wondering, is that something that do you think will become kind of a bigger focus of economic research perhaps in the near future, especially in the UK? Mark, you're nodding.
You want to answer, or shall I, or both? Or?
Yeah, you go first, and I'll add to that.
One thing is, I haven't found many studies looking at the impact of travel restrictions, actually, particularly not sort of modeling studies looking at what it might be. There have been a couple of studies looking at the impact that travel restrictions have had on tourism, and I think as you can expect, a massive decrease in tourism. There has been, I think, one estimate suggesting that the impact of travel restrictions on sort of business, trade in services and so forth, has been also substantial. I can't remember the exact figures, but nothing sort of saying this level of travel ban might have this impact or might have that impact. I mean, from an epidemiological perspective, I think what we are finding in the UK, where there has not been sort of like facility or hotel-based quarantine, there's been sort of home-based quarantine only, is that it can, I mean, the trouble is that when sort of adherence to that is not at the maximum, it can still allow sort of some spread. So that's the sort of thinking behind moving to a more hotel-based quarantine.
Yeah, and especially with, I guess, some of the discussion around new variants, etc., and trying to prevent those entering countries. Yeah, no, that was one that I was just thinking about. I think maybe time for one last question before we move on to your presentation, Mark. There's a quick one here, but will NICE assess the value for money of a COVID-19 vaccine, and if not, why? And I guess the answer to that is it's probably already too late. Vaccine rollout has gone ahead, or?
Mark, you go first, or I go first, or you?
Sure, go ahead.
I mean, my understanding is NICE had decided not to do that, and there was some consternation about it. But I also, I mean, I think the point that I would make is there's a difference between emergencies and post-emergency settings. I don't think, well, I have an opinion what I think NICE should do, but I don't think NICE should not do it. Very, very clear. I think probably most of us on this call value health technology assessment. I think what I've tried to illustrate is that decisions between costs and impact are being made, data is being generated, we're being asked for it. I think the issue is it's not this sort of decision frame that we're very used to in HTA is a challenge for us because it doesn't commonly, I mean, even though we know a lot of them say, look at a societal perspective, that hasn't been at the forefront. And I think there's a confusion that we shouldn't use cost effectiveness analysis because of the confusion with that, and it has to be a health sector perspective. So I think, to me, the failure has been that we haven't, instead of saying, well, we can still use economic evaluation, empirical measurement, valuations, methods, but we're now using a different part of them for a pandemic than we normally use. We've kind of chucked the baby out with the bath, as they say, the bathwater. We've said, actually, economic evaluation isn't worthwhile, and that's a misunderstanding of what economic evaluation does. So I would say I understand NICE is not currently doing it, but I think countries will have to negotiate price with, I mean, just on a really practical level within the health sector. Maybe now it's less of a concern, but I know that many countries are in price negotiations and do need to think about price, because this will be a long-term endeavor. So I've ranted there, but Mark, over to you if you want.
I completely agree. Well, I mean, one thing is that NICE doesn't usually evaluate vaccines. That's done by the NITAG in the UK, the called JCVI, the National Immunization Technical Advisory Group. But interestingly, JCVI has not looked at economic evidence, which it normally always does for COVID. And I think it's exactly for the reasons that Anna said, and which I also don't really agree with, which is that the conventional cost effectiveness methods don't work for COVID because so many of the costs or the spillovers are beyond the health sector. But I think that is really not a reason to not consider economic outcomes. It's a reason to improve our methods so that we capture all these additional outcomes.
Exactly.
Yeah, thank you both. Okay, so I think we're just at 1:45 now, so perhaps we'll move on to Mark's presentation. So are you okay to share your screen now, Mark? And then we'll try and get to some of the other questions. Sorry if we didn't get to them, but in the chat, we'll try and answer some of these during Mark's presentation.
Yep, great. Well, that was a really good, I'm going to follow on from Anna's slide, but that was a really good introduction to the sort of, really the way we've decided to split this up into two talks between us is my role is sort of straddling the epidemiological and economic modeling that's going on at the London School and elsewhere. So because I'm a sort of a bit of a mixed beast in the sense that I'm involved in a bit of both. So really looking at the epidemiological modeling issues and seeing how they link to the economic modeling issues. And that's maybe I'll build on from the introduction that Anna gave, which that really good introduction about the sort of economic outcomes and economic impact of COVID and related interventions, and talk about a bit about how some of the epidemiological modeling relates and intersects with that. And I'll end up talking about economic evaluation, which relates to the questions about vaccines, and I saw another one on antivirals. So the first one is to maybe just to give a sort of brief landscape of what's been happening in the epi modeling world in terms of this pandemic over the last 12 months or so. So I think Anna gave a good sort of like historical timeline of really what's been happening in the economic space in different phases. And maybe there's a parallel sort of like timeline in terms of investigation in the epidemiological space, in the sense that in the first part of the pandemic, wow, it feels so long ago, but we thought this was a problem restricted really to Wuhan or Hubei province at first. And actually the focus of the investigation was in understanding this outbreak, understanding whether it could be contained to Wuhan province or to China, and understanding the sort of basic epidemiology of the virus, like how long people are infected for, how many people they will transmit to, which are actually really basic, really key parameters in order to inform models. Then the next phase, I mean, I would call it maybe the European phase. I don't know if that's being a bit European centric, because there were also big outbreaks in other parts of the world, in Asia, in Iran as well. But well, I mean, the WHO Director General around that time said, you know, the epicenter of COVID is in Europe, and unfortunately for those of us who live in Europe, but that was where, you know, the most number of cases were, and where the start of the outbreak in the US and in the Americas as well was happening, but in Asia was actually starting to get under control in many, not all countries in Asia. And the focus there was understanding how the virus was transmitted, how fast it was transmitted, and what was the impact of interventions like non-pharmaceutical interventions, because that's all we had at that time to control it. By summer, this had become a global pandemic with outbreaks in most regions in the world. And part of the investigation was understanding actually what is the long-term epidemiology of COVID. So will people who are infected and recover, will they be immune to the virus? And if so, will we eventually see a decline because most people are immune to the coronavirus, or will they lose that immunity? And another question that I'm going to talk a bit more about is, well, many countries have introduced non-pharmaceutical interventions with restrictions on going out, with working, on economic activities. These have been very expensive, but they probably save lives. How do we find the balance between lives and livelihood? And I'll talk a bit more about that in a moment. And then now, actually, we're getting into what is a second or third wave, or even third wave in many parts of the world. And really the question is, well, what's causing these very dramatic increases in some places like Europe and the Americas, and actually in parts of Asia as well? What's the impact of these new variants? What's the impact of vaccines? And do we have an exit strategy, or are we going to be facing this COVID, for the rest of our lives, or at least for the next couple of years? Okay, so what I'm going to do now is to answer, well, really try to address the question which I think is really related to in the economic space, which is, well, what is the balance between lives and livelihood? And I think this is an important question, both because it's a question we're familiar with when we start thinking about, well, health technology assessments. Usually we say, we're going to intervene, we're going to introduce this new drug, and it's going to cost money, but it's going to save lives. And then we might bring that paradigm to COVID and say, well, if we close workplaces or close shops, it costs the economy money, but it saved lives. And this then even becomes a debate within policymakers. Like the sort of caricature is the Ministry of Health says we need to close we need to lock down the economy, but the Ministry of Finance says no, we can't afford it. Business has to continue. But well, here's a really nice sort of like graph that came out from Think Global Health just a couple of weeks ago, actually looking at different countries in the world. And on the x-axis, what you have is the number of deaths that these countries have experienced, while on the y-axis you have the GDP growth in 2020 compared to 2019. And what you see is that the curve is downward sloping. In other words, the countries that had more deaths also had greater GDP losses rather than less GDP losses. So the relationship between lives and livelihood, between economic costs and health, is not so straightforward. It's not like some countries had stronger interventions and therefore saved more lives but had a bigger hit to the economy. In fact, some countries, well, Vietnam, China, for instance, did not have much sort of economic impact, and also had a much smaller health impact compared to many other countries in Europe, for example. So the first thing is that, this is not a very straightforward relationship. Definitely it's not one where we can say, well, this intervention costs this much and saves this many lives. I mean, one way to look at it, Anna alluded to the sort of feedback loops that happen with COVID interventions. And really simplifying the loops, you could think of a loop that looks a bit like this. I mean, obviously it's much more complicated than, as you saw from the figure that Anna showed. But first of all, we have the epidemic itself. And if the epidemic's uncontrolled, then this has an economic impact. This increases medical costs. This decreases productivity because people are sick, or they die, or they need to take care of people who are sick, and therefore they're not working. It also influences private decisions to consume. So if there is an epidemic going on, people don't go out, they don't go to shops, they don't go to countries where there are epidemics going on. And so this decreases consumption, which decreases output, in other words, GDP. And it also induces NPIs. So if there's an epidemic, then governments impose NPIs, and these NPIs then have an economic impact as well. So what's happening? The NPIs are increasing medical costs as well. They're also decreasing productivity because people are not working, or people are not able to do trade as a result of the non-pharmaceutical interventions. But the NPIs decrease COVID-19 incidence, which then suppresses the epidemic, which then has a positive effect on economic growth. So there's this sort of feedback loop going on, and there are temporal lags between these. So it's not very easy to say, well, you introduce this intervention and the impact on the economy is positive or negative, impact of health is positive or negative. What you need is to really have an underlying model of what impact, first of all, the impact that the interventions are having on health, and then look at the impact of health then on both the microeconomic, on the sort of the microeconomic impact on taking sort of partial equilibrium assumptions on, say, the health sector or households, and the wider macroeconomy. So some attempts have been done to look at the relationship between NPIs and, for instance, RT, the reproduction number, which measures how fast the SARS coronavirus spreads, the SARS coronavirus 2 spreads. For instance, there's been quite a number of studies looking at this, but here's one of them, which I think is probably the most carefully done, using a variety of sort of machine learning techniques to look at different countries which have introduced NPIs and seeing actually what has been the impact of that on the spread of the virus. Actually concluding that some of the less disruptive NPIs can be as effective as the more costly ones. The problem with this, I think this is one of the better studies, and there have been many other studies, but the problem is that, well, actually, my colleague, Dr. Yang Liu, and some others, we actually wrote a paper doing the same kind of sort of like econometric studies, looking at the relationship between these different NPIs and the effect on the spread of the virus, but actually looking at various things that might confound this relationship. So first of all, regional differences. It might be different in different parts of the world. Looking at temporal relationships. So the NPI might be introduced today, but you only see the effect in a week or 2 weeks or even a month or more's time. Inaccuracies in our measurement of NPI stringency or the spread, the rate at which the virus is spreading. And also asymmetry. So what we found in many countries is when you introduce the non-pharmaceutical intervention, it has some effect on the transmission of the virus. But when the non-pharmaceutical intervention is removed, the RT doesn't necessarily go back to the original because people have changed their behavior, maybe permanently, or at least for the medium term. They've stopped going out as much. They've started wearing face coverings. They've stopped, maybe having so much physical contact with each other. So even when it is removed, you don't go back to the original state. And so all these relationships are really confounding the relationship, which suggests that you can't use these kind of statistical models to really accurately look at the relationship between the NPI and RT, except to draw really very broad conclusions. So another approach to look at that is really to, instead of using statistical approaches, try to mechanistically look at the relationship between interventions and the spread of SARS coronavirus 2. And so one of the early papers was, well, again, from one of my colleagues, Kisha Prem, really when the when the lockdown was happening in Wuhan, in Hubei province during the initial phase of the epidemic, looking at what really was the impact of locking down Hubei province, and what would the impact of then removing these interventions, removing these control measures. And really this concluded that these social distancing interventions, really the closing workplaces and schools, really having stay-at-home orders and travel restrictions, these substantially reduce the number of cases in Wuhan. And I guess now that's a very obvious thing, because the lessons from Wuhan have been repeated in many other parts of the world. But also that the conclusion we drew is that if these are not maintained, then a subsequent second wave might happen or would happen. And what we found is that this second wave in actual fact didn't happen, because there's one thing we didn't look at, which we then realized was going to be really important, which is actually surveillance. So when cases have been brought down to a very low level, then having a surveillance system, being able to detect cases very quickly, and then doing testing, doing contact tracing, doing quarantine, can then reduce COVID incidents, keep COVID incidents at a low level. And this is really a follow-on paper looking at the impact of different surveillance strategies in keeping incidents low. And I think especially in Asia, this strategy has been used very successfully. Once the initial lockdowns bring numbers to a low level, the surveillance, the contact tracing and quarantine and testing is able to maintain numbers at that low level. But this is quite intensive in terms of, well, testing facilities, in terms of contact tracing, which is sort of very intensive in terms of costs and personnel. So this has a cost as well, although obviously not as great as the cost of a large epidemic that we're seeing in Europe and the US. I mean, another input into this is really looking at what, not going straight from NPIs to the spread of the virus, but asking, well, first of all, what impact do NPIs have on, and like the question that I was asked, what impact do they have on social contacts between people, mobility in different sectors? And so this was an analysis using data from the UK, but could be done in many other countries in the world because the same data exists. Looking at a sort of circuit breaker, a mini lockdown that was imposed in the early November, and seeing what decline it had on people visiting, grocery stores or homes or recreation places or transit stations, and then translating that into how that would affect the spread of the virus. So this is the sort of modeling, the COVID-M model that we've been using in the London School, which Anna showed in her sort of big graph showing how the epidemiological modeling relates to the economic modeling. And this is really, what's modelers call an SEIR model. It's a model that looks at people as they are susceptible to infection, then they get infected, and then they recover, and maybe they are immune for a while or for a longer time. But these models really need to take into account, well, one is social mixing between different people. So that's the sort of data and synthetic data that I talked about in answer to one of the questions. But also looking at data on mobility, how much people move between different parts of a city or a country, and also looking at data on cases and maybe also virological testing or serological testing. So look at how many people are infected now and how many people have antibodies because they were infected in the past. And bringing this together in a modeling framework so that it can then inform outcomes like how many cases you're expecting to get, how many hospitalizations, and how many deaths. One challenge, and this has actually been done by a number of different modeling groups, not only the London School group. So I think I should mention that WHO has brought together a number of groups doing this around the world. I think the sort of initial phase lists these groups that initially took part in this exercise, but now WHO is starting to expand it to actually starting to talk to groups not only in these sort of high-income countries, but also groups in low and middle-income countries, which have been also very successful in applying modeling to understand the spread of the coronavirus, such as HITAP, for instance, and other groups around the world as well. But I mean, one challenge we have in this is that the data we're getting sort of cannot be taken at face value. And I'm not just saying this about certain countries. This is true of every country in the world. The number of cases reported does not represent the true number of cases. So this is a nice graph on the right from the BBC actually, pointing out that actually in March, when a lockdown was imposed in the UK, only 5,000 cases a day were reported, but some modeling we did actually suggested the true number of cases was about 100,000. Then currently we're reporting far more cases than that, but actually because testing has, the rate of testing has increased dramatically, the true number of cases is probably at the moment in the UK less than we had in March. And this has been repeated in other parts of the world. For instance, this was a study by John Ojal and colleagues at Kemri in Kenya, actually taking both the number of cases and deaths and also data from antibody studies who has been infected in the past, and suggesting that actually among the urban population in Kenya by August 2020, about a third or more of the urban population of Kenya had already been exposed to the coronavirus. So these kinds of studies allow a true estimate of the number of cases of coronavirus, which aren't very well represented in just the sort of like national figures on cases or even deaths a lot of the time. So those are some of the challenges in the epidemiological modeling, which then needs to inform the economic modeling, and the importance of making sure that the two are well linked. I'm now going to speak a bit about looking at economic evaluation. So the question about when we do have the interventions, whether they're vaccines or someone mentioned antivirals or maybe antiviral treatments, remdesivir, for instance, or increasing hospital capacity. How do we evaluate whether this is good value for money? And the traditional way to do this is actually to do a for instance, a cost effectiveness evaluation, looking at what's the cost of the intervention compared to the cost savings to the health sector, or maybe wider than the health sector, and comparing that to the lives saved or the DALYs or averted or QALYs gained as a result of the intervention. And as health economists, you're probably very familiar with this. And this has been used. For instance, here's a study that came out recently looking at, well, different strategies for COVID-19 control in South Africa, and using those kinds of outcomes, the health sector cost impact and the health impact, and seeing whether different interventions are cost effective. And this is one approach, but because the sort of effects of COVID-related interventions are so broad across society, there have also been sort of attempts to take a broader perspective. So here's a study from some colleagues, Frank Sandman and other colleagues, looking at the impact of vaccination, but not just on the health sector or on health, but looking at GDP. So really suggesting that a highly efficacious vaccine, which is able to be rolled out quickly, could save the UK economy, something like 5%, 10%, or 50% of GDP by averting some of these lockdowns that might otherwise have to occur. So as you probably know, the macroeconomic, the wider economic impact of these interventions can be enormous. And then a third approach is to try to combine the two, to say, well, there is the impact that these interventions have on the economy, but that only calculates the economic impact. People also care about the health impact. And so here's a study looking at social distancing, but comparing the cost of social distancing in terms of the impact it has on the economy to the value it has in terms of reduced mortality, and converting that using a value of statistical life measures to sort of trade off the value that people put on averting mortality to the impact it has on the economy, and seeing, okay, under what circumstances is it justified to have an economic loss because you saved this many lives. So I think just in the last few minutes, well, here are sort of different approaches you can take to doing economic evaluation. Maybe I won't go through all of this just for lack of time, except to say that I think in the economic sphere, we are still working out what is the best evaluation to use. The traditional cost effectiveness analyses, especially those from a sort of more limited provider perspective, don't seem to be addressing the questions that governments are asking when they want to decide, should we buy the vaccine or should we impose a lockdown? Because they're more interested in sort of much wider measures on the economy. And maybe as economists, we need to start to think about, how do we take a wider perspective? How do we look at macroeconomic impact? How do we look at the sort of the impact that is not so easy to capture even with any of these measures, such as the impact on mental health, for instance, or on human capital accumulation, or on sort of liberty, for instance, and sort of being able to bring all these metrics together to inform governments. So I'm just going to end by giving a few key messages from both Anna's talk and mine. If Anna's here, I don't know if you want to talk about the first few bullet points, or if not, I can go through them. Yes, I think first of all, the important point you made is that the costs to the health sector, to households, to the economy of this pandemic have been far greater than really anything we've seen in such a short space of time in the history of health economics. So this is really hopefully a black swan event, a real outlier event that we have to really think hard about how we do the economics. The policy response is about balancing health and economic outcomes, but also about who bears the cost. So it's not just the aggregate impact on the economy, but actually who are the people who are bearing the cost, and are they able to bear it? Are they the households that are least able to bear it? And actually, they're both demand and supply side health related constraints. There's the hospital supply side, there's the supply side in the economy, but there's also the demand side of people accessing care, people buying goods and services in the economy. And the relationship between lives and livelihood is not straightforward. It's not just that, you impose this, it costs this much, and it saves this many lives. It's actually sometimes non-pharmaceutical interventions, if introduced at the right time, can save both lives and improve economic growth, because they avoid the negative impacts of a large epidemic. And we really need epidemiological models that dynamically capture the impact of things like physical distancing, contact patterns, the disease natural history to look at this. And finally, all COVID-19 related interventions have economic costs. They have opportunity costs. If people are, giving out a vaccine, they are not doing other things. But for these economic evaluations to have policy traction, I think we do have to do the economic evaluations. The economic dimension of these interventions is so important and has been driving government decisions. But for the economic evaluations that we're doing in academia or in HTA agencies to have policy traction, we really need to find a way to measure the full range of benefits and costs of the intervention, and not just the sort of microeconomic health sector intervention that we're more used to when we've done, for instance, an HTA of a drug, which has an impact mainly on the health sector and on the lives of a few individuals. So I'm going to stop there, but really happy to take questions.
Awesome. Thank you so much, Mark. Yeah, that was really great. I think, yeah, if people could get in there with some questions in the Zoom box, and then we can start asking those. I think one of the things just that I was wondering, and particularly for you, Mark, I guess, because vaccines are more your area, but for now that we've kind of got these vaccines out there and they're being trialed in various countries, and we've obviously got the clinical trial evidence, but in terms of real world evidence, what kind of things do you think economists will be looking for that's kind of emerging to inform like health economics and decision making on that in the future?
In terms of vaccines, well, I think one of the challenges we're going to have is that so many things are happening at the same time. I mean, countries are introducing vaccines, and these will have an impact on, we hope, will have an impact on the spread of the epidemic. And that will have an impact then on economic growth, because if people are vaccinated or if the cases are low, people will have, well, have more confidence in, consuming. Private consumption will increase. Governments will be able to lift lockdowns. But at the same time, the vaccines are going on. NPIs are having an effect at the same time. I mean, the spread of these new variants we're hearing about, they also have a negative impact. They also increase the cases, even while vaccines are decreasing the cases. So really understanding, being able to disentangle this will require a lot of, first of all, careful epidemiological studies, and then studies then to say, well, if this is happening on the epidemiological space, how does it translate into the economy? I think it'll be very hard to just say, well, this country introduced a vaccine and then the GDP changed by this much, because 5 other things were going on at the same time. But Anna wants to add anything to that. So.
Yeah, I think I totally agree. But I think just to help do that unpicking, I think what would be useful is to understand uptake by different groups. I think that's something that would help, maybe less understanding what's happened, but would actually help better modeling going forward of what we think the impact of vaccines would be. And also, again, behavioral studies around how people who are vaccinated decide to change their behaviors, I can imagine would be very useful. Again, less, I think Mark's completely right. I think one of the big challenges has been to unpick why the epidemic is behaving like it is with so many simultaneous things. And I imagine from the macroeconomists, it's exactly the same, trying to unpick these things. But to try and model them going forward, that would be some real world data. I mean, obviously that's aside from all the clinical, effects, the stuff that post-vaccine rollout monitoring on immunity and whatever. The other thing I'd say, it does also apply for the health service. Again, people sort of real world access. The other part of the model is looking at the savings you have in terms of reductions in treatment. So understanding how people are accessing care when they have COVID across different settings is also really important.
Actually, one more thing I'd like to add is, I mean, both of us have been saying that this is really complicated. I mean, everyone is finding it. This is one of the most complicated epidemiological and economic problems we faced in the infectious disease space for many, many years. But I also don't want to, I think the economists here operating in all sorts of circumstances, you might be the only economist in your whole institution, or you might have an incredibly strong team. I'm sure there's a whole range of these. And just want to say, don't get discouraged and think this is all too complicated. Let's forget about it. First of all, there are tools which are being put out, some of them designed for sort of like people with an economics background or with a modeling background, but not necessarily having to start from scratch. WHO is supporting some, London School, Imperial, Johns Hopkins. People are putting out tools, and also there are opportunities to collaborate. So that's not to say that, some of you are from really strong institutions. I'm sure you can do it on your own. You don't have to get someone from London to make a tool for you, for many of you. But just to say, if this feels a bit overwhelming, you don't have to start from scratch. So to also assure you, because the work that all of us are doing is incredibly important. So it is important to get it right, but it doesn't sort of feel too overwhelming as well.
Yeah, no, I think that's been a big thing that we've seen, definitely, in terms of partnerships between academic institutions helping with the modelling all around the world. So there's also a question directed at you, Mark. Talking about your last point about taking a wider perspective when conducting economic evaluations on COVID-19 related interventions, do we need to do the same across health interventions? Should we all revise the current economic evaluation guidelines around the world? And will this be a barrier or onus or for generating evidence to support health policy in the future? Do you think that that's quite a big question?
Well, I think to some extent it's a normative question. So some countries have decided to use a health sector's perspective in their economic evaluations for normative reasons, because they think the main purpose of most medical interventions is to improve health and to reduce the burden on the health sector, and the wider societal benefits are not the main focus. So I think that's perfectly a legitimate position to take. But with COVID, that's clearly not the case. And that's really untenable, because we all know that governments are making decisions about COVID interventions based on factors far beyond the health sector. So there's no way we can say, it's not tenable to say for COVID related interventions, we are going to take a health sector perspective. If you're looking at a new cancer drug, for instance, I think it is still it's a defensible position to take. I'm not saying that's the only position you can take. Some countries do use a societal perspective, but there is perfect justification for saying we would rather just restrict the scope to the health sector. That's my opinion.
Yeah, I'd like to add there. I mean, I think for those of you who've seen the US second panel recommendations, they have what they call an impact inventory. And for my area, because I've less been working with cancer drugs, but more around HIV and TB, where some of the interventions are also social interventions, we found that very useful, because at least as your starting point, you can go down that and you can start to think, well, are there important impacts here? And if there are, maybe there is a justification for including them. And I agree with it. So I think there's an analytical perspective there. Now, I agree with Mark that some decision bodies don't actually require you do that. But in some cases, it is useful, because you can encourage ministries to work with other ministries who may have other impacts. So you might have a program that does have a substantial external spillover effect to the education sector. And often that, even if it's not done at the big sectoral level, it may enable the Ministry of Health to go to the Ministry of Education, say, this is not cost effective for us, but because it has this big spillover for you, if you can co-finance this, then now this intervention can happen. So, and that's important if we want sort of multi-sectoral interventions to happen, as well as just, as you say, the cancer drug. So I think it depends, one, on the decision frame, but also the intervention, and that checklist from the US panel is a useful way to just think that through and then decide as an analyst what you want to do. So I think it's there, actually. I think we do have, I mean, that's part of my frustration. I think actually we do have it there. And it's no change in our guidelines. It's just actually using some of the guidelines that exist, but spending that time to do it. I have to go now, so I'm going to say goodbye, but it's been great to do this, and I'll leave Mark, thank you, Mark, to answer the rest of the questions. But thank you, HITAP, for organising this from my perspective, and bye-bye.
Bye, Anna. Okay, Mark, so it's you on your own now. So I think one of the other questions was just more of a request really to talk about generalizability and transferability of health economic studies. So I guess if you're in a country where you haven't conducted this research yourself, perhaps like what things you need to think about or prioritize when thinking about the generalizability of different studies in other countries. Perhaps you could touch upon that.
That's a good question. I think the same sort of principles for generalizability of all health economic studies still apply. So I mean, if the country is does the country have sort of a similar healthcare system, is similar burden of disease, and so forth, then it might be more generalizable. But for COVID, I think you additionally have to consider whether the country is in the right sort of epidemiological situation. So for instance, WHO has put out guidance on how countries should prioritize COVID vaccines to different groups in the country. And they've really divided countries into many different categories. So there are countries where there are really like big epidemics, like the UK and many European countries. There are countries which have, smaller epidemics, which are to some extent under control, but there's still ongoing transmission, like many in Asia, for instance. And then there are countries like, China or New Zealand, where the number of cases is really quite small compared to the population, and most outbreaks come under control. And so the way these vaccines should be used will be very different in all these different categories of countries. So maybe when generalizing, also considering the sort of epidemiological situation as well as the usual things you'd consider for generalizability.
Perhaps Mark as well, if you're able to field some of these. I'm just scrolling through them now as we've got a few. There's any that stand out to you? I think there's one about whether there's, I guess this is more a question of your knowledge of the literature, but are there any models that tried to show the impact of non-pharmaceutical interventions on both the health and economic impact in order to guide kind of more balanced policy interventions? And if there's examples of other countries that have used these to guide their policy decisions?
Yeah, there are a couple, not a lot, I must say. There has been some, as I said, there have been some sort of more econometric studies retrospectively looking at the economic impact of COVID. Actually, there are quite a lot of studies like that. There's been lots of epidemiological models trying to model what might happen with COVID under different scenarios about interventions. There have been not so many pieces of work combining the two and actually having a very realistic model of the disease, but also looking at the sort of wider economic consequences. And I think partly the lack of work in this space is why governments have not been able to rely too much on this data. I think there's a real need for it. I mean, for instance, again, in the vaccine space, WHO has put out a call for more evidence in this space. So it's not that decision makers are not looking for it. It's just that there hasn't been so much. But there have been a couple of studies, and I'm sort of happy to share them if people are interested, like send a couple of papers looking at that. Yeah, thank you.
Either if you don't have time, maybe you can send them and we can send them out on our email afterwards, because we'll send a summary to everyone who registered. Okay, another question here, I guess a bit of a Southeast Asian focus, but are there any unique considerations to take when performing economic evaluation studies on COVID for Southeast Asian countries?
Well, if there's anyone in your team from Southeast Asia who'd like to answer that. I think there's a lot of variety in Southeast Asia. I mean, there are countries like Singapore and Vietnam which have quite small numbers of cases, and there are a couple of countries in Southeast Asia which have quite large outbreaks too. So I think it's quite hard to generalize, but maybe anyone in HITAP would like to comment on the Southeast Asian perspective.
I think that was my concern too as well. And I think one question I also had is whether with the rollout of vaccines and the very differing levels of kind of cold chain requirements between some of the vaccines, how that, if that can find its way into vaccine modeling? Is that something that's been done much?
Yeah, I think that's a great question. And actually, I think that's a question where modeling and economics is important, but actually in a sort of space where there are a whole number of considerations. One, which is, okay, these different vaccines are not identical. They're going to have different impact. Two is logistically, some are going to be easier to deliver because they don't require ultra low temperatures, or some of the current vaccines being trialed might not even require 2 doses. Might only require 1. But then there's also considerations like the cost of these vaccines is different. Some of them are more easily accessible, like they're accessible through the COVAX initiative, or in larger numbers through COVAX, and some are not. So I think countries are going to have to make these decisions based on economics, definitely, but also logistics, supply, acceptability. I mean, there is sort of like more acceptability for some vaccines than others in different countries based on maybe like historical ties with the manufacturing countries and so forth. And so there are many other considerations too.
Yeah, no, that makes sense. How do we effectively bridge epidemiological data with economic evaluation studies and policy making? I guess that's largely.
Yeah, that's a great question. And I think on the epidemiological modeling space, there's been more policy traction, I think. So policymakers have asked modelers what will happen if we have a lockdown or we don't have a lockdown, or if we close borders or not. On the economic space, I think there's been I think ministries of finance, treasuries have been doing a lot of fiscal modeling to look at the impact of these interventions too. But actually, the space of actually bringing them together in the kind of evaluations that maybe a lot of health economists are used to doing, as I said, that's not had as much policy traction as probably both Anna and me think it should. And I think probably that's a challenge for us actually to be talking to policymakers, asking them what kinds of outputs are most useful to them, and then being able to link up as the economists, being the people who can link up with the epidemiological modelers and design the economic evaluations that can produce the outputs that they're interested in. Because governments are looking at economic and financial outputs from the Treasury, and these are based on much simpler models than the ones we're probably used to even in our normal day-to-day work before COVID. And so I think if we are able to produce these output for them, I think they will be really very useful, since I mean, governments are facing this dilemma of, what can we do when there is an epidemic? It will be costly to introduce these interventions, but at the same time, if we don't, the consequences might be bad.
Yeah, no, I can see that. I think also we've got an interesting question here. I've also noticed, but I hadn't really thought too much about, but I've noticed that most studies, so this is the person who asked the question, most studies presented by Anna and Mark weren't published in health economic journals. And are there any reasons for this, and how can health economists in LMICs keep updated around the kind of state of the art on COVID related articles and health economic modeling, if it's all kind of spilling over into other kind of genres of literature, I guess?
That's a good question, actually. I think part of the reason there has been a lot of literature in health economics journals, but it hasn't been as immediately policy relevant. I think part of it is the sort of publishing timescales, where most medical journals have sort of introduced very fast track reviews of COVID-related articles. I think economics journals have not. Some health economics journals have been sort of straddling the space in the middle of the two, and some of them have, and I've seen some papers published in those. The other thing is some of this work has not been published in journals at all. They've appeared on preprint servers or on websites of institutions or universities, and I think there's some caution about using that because they're not peer reviewed. But at the same time, if you read them and do your own assessment of them, even though they're not peer reviewed, read the methods carefully, make your own assessment of them. It's better to have, I think, some evidence that you will feel comfortable with the methods today rather than to have a peer-reviewed paper in 3 months' time when the decision's already been made. So you have to find the balance there.
Yeah, and I should say, I think in relation to the last part of that question, is that a great resource for keeping a breadth of this literature is the C19 Economics website as well. So I think we've already shared the link in the chat for that. Let me just check one time. Okay, so we are at 12:30 now. So perhaps we will close there, but I would just say thank you so much, Mark, for joining us, and also to Anna that she's not here. But yeah, we will be in contact with everyone who registered and attended the event with kind of follow-up information. And yeah, hopefully you've enjoyed the webinar, and we've kind of been keeping this series of technical health economics webinars going approximately once every 2 months. So look out for another one, I would guess, in around towards the end of March. And yeah, we will hopefully see you there at that too. So thank you, Mark, and thanks everyone for attending.
Thank you. It's been great questions, and very good to interact with everyone.
Thanks. Right, we'll close there then. Thank you.